morning, everybody. I am Dr. Pankaj Puri. I am from the Fortis Scots Hospital in New Delhi. Let me welcome Dr. Arun Sanyal. Dr. Sanyal is the professor of medicine in the Virginia Commonwealth University. He's the past president of the AASLD. He's the chair of the NIH study section and is the founder member of the American Board of Transplant Hepatology. He's the senior editor of Zakim and Boyer textbook of hepatology and is the chair of the NASH Clinical Research Network of the NIH. So welcome, sir.
Thank you. Thank you. It's a pleasure to be here.
We have a lot of patients who come to us and talk to us about, I have fatty liver, so what? And people would either ignore it totally or become fatty liver neurotics. So how far should they worry?
Well, they should pay attention to it and not get obsessed with it. So having extra fat in the liver increases not only liver-related risks for specific subsets of people who have inflammation and scarring in their liver, something we call NASH. And then there is also implications for cardiovascular disease and for increased risk of cancers. So having excess fat in the liver tells us that there are processes going on in the body that are going to impact the long-term health of the person. So it is important to pay attention to it, but not necessarily get obsessed with it.
So we have people who have fat can have just simple fat, but they can have a lot of liver fibrosis and inflammation, which we call NASH. Now, how would you go ahead and differentiate between the two?
So this is really a very important question for the practitioner when facing a patient suspected to have fatty liver disease. Having extra fat in the liver can be easily diagnosed with a number of tools such as FibroScan, etc. But the more important question is this person the person whose fat in the liver will eventually hurt the patient or kill the patient? And that is really contingent on how much injury and how much scarring there is going on in the liver. So probably the best way to start this process is by assessing if once you've established there's fat in the liver with a simple imaging test such as FibroScan. They are more expensive imaging tests like MRI, but probably not substantially superior to a FibroScan for routine purposes. But for understanding who is going to actually die from their fatty liver disease, knowing how much scar there is in the liver is extremely important. And again, a great place to start is by either using a simple test like a FibroScan, where if you have a liver stiffness over 8, then pretty much suggests there is some scarring going on. Now, another test that can be used where FibroScans are not available is called the FIB4 test. And this is based on 4 things: the age, the AST, the ALT, and the platelet count. And there are very simple calculators available online where you put these in and it gives you a number. If that is less than 1.3, you can reassure the patient that they have very little scar in their liver and their risk of actually dying from liver disease over the foreseeable future is minuscule. So these are great tests to be able to exclude the presence of significant liver disease. Now, if your numbers are higher than this, then you have to worry how much additional scar tissue you have. So if the numbers are over 2, for the FIB4, it is more than 3 or 3.2. If the FibroScan level is over 14 or 15, then you start worrying that they already may have silent cirrhosis. One of the things to remember about fatty liver disease is that the liver is a very forgiving organ. So it will not tell you there's something wrong until things are very wrong. So if you wait for symptoms to develop, you're waiting for the disease to progress to a very advanced stage. And so it is important for physicians to be aware that the disease can be silent, and in people with risk factors to look at the FIB4 and maybe perform a FibroScan if there are substantial risk factors, which are typically obesity, type 2 diabetes, dyslipidemia, hypertension. So if you have those, then I think it is important to screen those patients to find out if they have fat, and if they do have fat, how scarred their liver is.
So often you have people who come to you with just fat in the liver. The basic liver functions are normal. And how far would you advise them to be investigated?
I think if the FIB4 is less than 1.3 and the fibroscan shows that their liver stiffness is less than 8, then that's the end of the investigation. Their primary risk is cardiovascular. It is also very important not to tell the patient that don't worry, your numbers look good, go do whatever you want. This is the opportunity to engage in a healthy lifestyle, improve your cardiac risks, because that is the largest risk to life for those patients, because there is excess cardiac mortality in people who have even some fat in the liver.
Where is the subgroup of people whom you would like to do a biopsy? Are you avoiding biopsy totally?
No, we have become much more selective. Everybody throughout the world, I think, is doing far fewer biopsies today than they were doing 10, 15 years ago. And that is because some of the non-invasive tools have become very good at excluding people who have significant disease. Now, the positive predictive value of a lot of these tests, such as fibroscan, etc., are not very good. So when in doubt, about the positive predictive value, if your numbers with these simple things don't give you a clear answer, then sometimes you have to think about doing a biopsy. But that answer to whether you will do a biopsy or not should also be linked to what are you going to do with that information. If you're going to use a more expensive drug, something that costs money, you're going to use a GLP-1, something else that is, that you're making a substantial investment. You want to be sure that you are using the right type of therapeutic tools or drugs, which also carry some side effects and risks, only in people who are most likely to benefit from the drug. So that's where I think a biopsy still becomes useful. So at the extremes, when you have almost nothing in the liver or you have cirrhosis, we have become very good at making those diagnoses. It's in the intermediate subset on a case-by-case basis that you make the decision to do a biopsy.
We have a patient today and we say he has fatty liver, no evidence of NASH, his fibroscan is good. So how would this would be the pure fatty liver and he doesn't seem to have any evidence of NASH? What would be the progress in these patients?
So a subset of these people will progress over time. The exact proportion who will progress is not really known, but it is generally felt that about 20-25% of people will continue to progress over time. And then eventually this can lead to cirrhosis. Now, a good readout of that is if your liver stiffness starts increasing. So for people who have low levels of liver stiffness, whose FIB4 levels are low, it's probably a good idea at 1 to 2 year intervals to recheck these, to make sure that these levels are not going up.
Once we have a person with NASH, what's the advice you'll give him besides, say, alcohol, diet advice? And then what would be the specific drugs which you would look at?
So, I just want to make a couple of points about diet, because we tend to just say, oh, you need to lose weight, but that does not translate for the patient very easily into something that they can actually do. It requires a little bit of effort to understand their lifestyle and their diet and why they eat what they eat. So, for somebody who's a shift worker at night and has a little bit of time at home to come sleep, and then particularly for the ladies to cook for the whole family, and then everybody has their own special story. So it's important to understand their background. The lifestyle and diet recommendations have to be given in the correct socioeconomic and cultural context. Telling someone who is used to eating rice and fish to then suddenly eat a Mediterranean diet with pasta and olive oil, or with olive oil, it doesn't work. Telling a Japanese patient to take a Mediterranean diet or a Mediterranean patient to eat a Japanese diet does not work. So it has to be in the right context. And then you have to engage in the whole family. If the whole family is eating one type of food and you're telling one person to eat a different kind of food, the reality is that never happens. So I think that's very important, to engage the family in that discussion. And typically the mother is the central key point. If the mother is a believer, the whole family becomes a believer, because mothers change how the whole family structure works. Then we get to drugs. So we typically restrict drug therapy for people who have at least stage 2 fibrosis or more. So that would be a FibroScan liver stiffness of 9 or higher. And right now there are no approved drugs, at least in the US, for the treatment of NASH. Now there are some drugs available that are off-label use, and of those, for people with lesser degrees of fibrosis, non-diabetic patients, vitamin E is a good choice. There are other drugs like pioglitazone, which also are quite effective, but can make you gain weight. So you have to then watch the diet and have a real good exercise plan to limit that weight gain if you're going to use pioglitazone. GLP-1s are now coming online. There's limited data, but it suggests that that class of drugs may also improve, the liver disease. Now, GLP-1 is very special because that class of drug has been shown in type 2 diabetics with high-risk cardiovascular disease status that it produces all-cause mortality benefit. It also improves cardiovascular mortality. And there's evidence that it improves liver histology also with small studies. Larger studies are coming, but that's a very attractive class because it hits all the things that are going on in the patient. One thing to remember is that NASH does not happen in a vacuum. NASH occurs in the context of obesity, heart disease, chronic kidney disease, and GLP-1s also stabilize the GFR. So it's a really good class of drugs to think about in this population. In India, saroglitazar is a drug that is being studied. There's some early emerging data that I will actually show here at this meeting that looks extremely promising, and it's approved here for diabetic dyslipidemia. So again, a lot happening in this field, but I think the pioglitazone, vitamin E, and GLP-1s are off-label uses, but there's evidence to support their use. Obeticholic acid is the first FXR class molecule, and actually the first drug that has gone through what we call the pivotal trial process in the US and has read out positive. That paper just came out in Lancet last week, and so I'll show some of that data at this meeting as well.
Good, sir. Thank you so much.
Thank you. It's been a pleasure.
There's so much to look forward to. NASH is something, and it's been great to hear from you. Thank you.
Likewise.
Thank you very much.
My pleasure. Thank you.
Thank you, sir.
Thank you.